I'd like to talk a little bit about what are fibroids. Fibroids are benign smooth muscle cell tumors of the uterus. They are very common. About 80% of women have fibroids, but that doesn't mean everyone is symptomatic from fibroids, and it doesn't necessarily mean everyone needs a procedure to remove them. Fibroids can grow really in any part of the uterus. So some fibroids can grow out here. They're called exophytic or subserosal fibroids. Some fibroids can grow in the wall of the uterus. These are called intramural fibroids. Other fibroids can grow actually inside the uterine cavity here. These are called submucosal fibroids. Now, depending on where the fibroids are, they can cause entirely different symptoms. So, for example, fibroids that are inside the cavity can be really small but cause a lot of heavy bleeding. Whereas fibroids out here can actually get very large before they cause any symptoms, because the symptoms you might have from a fibroid out here would be more like pressure or bulk symptoms, where you might feel pressure on your bladder or your bowel. Depending on fibroid location, this may also impact pregnancy or cause infertility. A hysteroscopic myomectomy is a procedure where you do need some sedation, so you are asleep. And then what we do is we insert a small camera through the vagina, through the cervix. So there aren't any actual incisions, we just use the natural openings. And then with this small camera, we essentially shave away the fibroid until it's all the way removed. This procedure is an outpatient procedure, meaning you go home the same day. It's very well tolerated. Actually, most patients don't have any pain. You may just take ibuprofen afterwards. And the restrictions for recovery are nothing in the vagina for 2 weeks, because we dilate your cervix, so we don't want you to get an infection. So no tampons, intercourse, baths, or swimming. But usually you can return to work and your other regular activity the next day. During the hysteroscopy, we actually use fluid to help us see. So first we insert the camera, and then we use fluid to open up the uterus to help us see. With the fluid, we can only use so much fluid. So what happens is some patients will absorb the fluid through the uterine wall, or some of that fluid will go out through the fallopian tubes and then get absorbed in the abdomen. It's kind of like giving you IV fluids. So what we do during the procedure is we monitor how much fluid is getting absorbed by the body, and we have to stop when your body reaches a particular limit. Most of the time we're able to complete the procedure within that time period, but every now and then we have to stop the procedure if we reach the deficit limit and have to do it again another day. The reason for this is if we give you too much fluids, it can lead to electrolyte abnormalities that can be dangerous. Other risks of the procedure would be what's called a uterine perforation. So there's a really small chance that when we dilate the cervix or put the camera through the cervix, there's a chance we could poke a hole through the other side. Usually that's not a very high risk complication, and typically what happens is we just stop the procedure and that little perforation heals. So typically it's not very dangerous if that does occur. Other risks of the procedure could be infection, but that risk is so low we don't even give you prophylactic antibiotics. And then there is a small risk of bleeding. You may expect a little bit of bleeding after the procedure, but it's not usually anything heavier than a light period. As I mentioned, a laparoscopic or robotic procedure is also a minimally invasive procedure. So this surgery is usually done through 4 or 5 small poke incisions that are about 8 millimeters in size. The first thing we do is put the camera inside the incision that's made near the belly button, and then the other little incisions are for our other instruments. Once all our instruments are there, what we do first is actually inject the uterus with a medication called vasopressin. And what this does is actually constrict the blood vessels so that you have less bleeding during surgery. After this, then we find each fibroid, and usually fibroids are mostly contained inside the wall of the uterus called the serosa. So what we do is we open up the wall of the uterus, shell the fibroid out, and then we set it aside, and then that leaves basically a small divot in the uterus where we then suture that up in multiple layers. We do this procedure with each subsequent fibroid until they're all removed. Once all the fibroids are removed, then what we do is we actually place the fibroids in a bag. It almost looks like a big Ziploc bag that we put in your abdomen. We put all the fibroids in the bag, and then we bring this bag out your belly button incision. So your belly button incision does get extended a little bit, but it's not usually bigger than maybe an inch, inch and a half. But this is where we take large fibroids out of small holes. In order to do that, we actually cut the fibroids into small strips. Once we remove the strips, then we send those off to pathology, where they will make sure that those are benign. Those results typically take about 3 to 5 days. The reason we contain the fibroids in the bag is because there is a very small risk of cancer in a fibroid. This risk is less than 1%, and unfortunately there's no way to know if there's cancer in a fibroid prior to the procedure. So for example, we can't tell on any CT scan or MRI, and we can't biopsy the fibroid ahead of time. So during surgery, we essentially treat the fibroids like they're a cancer, just in case. And part of that is when we place them in the bag and we cut them in small strips, while we're cutting them, we don't want those cells to spread throughout the abdomen, so that's why we contain it in a bag while we do that. Risks of this procedure could include bleeding. So we do get your consent for a blood transfusion just in case of emergency, but again, that risk is less than 1%. Other risks include infection, so you get 1 dose of antibiotics while you go to sleep. Risk of injury to nearby organs, so what sits next to your fibroids are your bladder, your bowels, your ureter, which is the tube that carries the urine down from the kidney to the bladder, as well as your fallopian tubes and ovaries, because we don't always know how the fibroids are related to those prior to the procedure. All of those risks are way less than 1%. There is also, unfortunately, a risk of hysterectomy at the time of myomectomy, which is also exceedingly rare. However, if there's a case where we weren't able to reconstruct the uterus, or you had significant bleeding that we weren't able to control any other way, we may have to perform a hysterectomy if it would be life-saving. After this procedure, it is outpatient, which means you go home the same day, and usually you have about 2 to 4 weeks of restrictions. So because we make a slightly larger incision above the belly button, in that incision we actually need to close what's called the fascial layer of the abdomen. And that's what holds all your abdominal contents in. And if that were to open, you could get a small hernia. So usually we say no vigorous exercise, no heavy lifting for about 4 weeks. We encourage walking, and most patients are able to return to work within 1 week, depending on the type of activity required at their job. If you are considering pregnancy after a myomectomy, specifically a robotic or laparoscopic myomectomy, you do need to give time for the uterine incision to heal. Depending on where the fibroid is, it would be recommended that you wait at least 3 to 6 months prior to trying to conceive. And this is because those incision points are weak, and we want them to heal well so that you don't have a risk of what's called a uterine rupture at the time of pregnancy or delivery, which can be catastrophic for both the mother and infant. Another thing that may be recommended is a cesarean section for future deliveries, again, to decrease this risk of uterine rupture.